Bismillahirrahmanirrahim. First of all, I thank the organizers for introducing me in such a lively way. And I was telling that last time's introduction, I was never annoyed. It was just a rectification, nothing else, nothing more than that. And I'm grateful for inviting me for the second time. Dr. Tariq asked me to give you the handout of my presentation yesterday only, and most of the time, even myself is amongst almost all the consultants who are too busy and may not prepare their lectures, say more than their slides. And so I had decided, I had brought the asthma guidelines, practical asthma guidelines which have been prepared by Pakistan Chest Society. Pakistan Chest Society is the active body of the Pakistani chest physicians, and I had the honor to be its central president in 1997 to 99, and then for last 4 consecutive years, the people are elected for 2 years. I was the Punjab provincial president, and for all these 3 times chairs, I was elected as unopposed. So actually there's a lot of unanimity amongst the chest physicians, and these are the consensus guidelines on asthma. Of course, we have a lot of help from naturally from other guidelines, from GINA guidelines, from British guidelines, and then naturally you will find a list of the sponsors. Naturally pharmaceutical people, some of their names have been added to that, but they are absolutely unbiased. So they'll guide you. So all of you can have 1 copy of that. I have given to the organizers. I really appreciate and congratulate you for being here since morning and beating me at 4:15, 4:20 p.m. and that shows you a lot of interest, and specifically formally the people have been talking that our general practitioners are not interested in continuous medical education or learning, but this negates entirely that thinking. So I congratulate all of you and the organizers. Okay. Now bronchial asthma, all of us we know. मेरी आवाज़ ठीक नहीं है? मेरी पहले आवाज़ ठीक थी या ठीक है? अब एको आ गया? Oh, I'm sorry. I was thinking that probably I'm avoiding echo. I do. Now is it okay? Can you listen, sir? It's okay. Now asthma, the concept should be clear. The general public always think about that asthma is allergy, allergy is asthma, and vice versa. So now our concept should be clear that it's a chronic inflammatory disease which is characterized by hyperresponsiveness of the airways, which is clinically manifested by wheezing, cough, and breathlessness. And clinically all the 3 things may be there, 2 of them may be there, or only 1 of them may be there. But somehow when the wheezing is there, and the nature of the disease in majority of the cases is the disease is episodic, so then the diagnosis is not difficult. So if I repeat it, you have read that it's a chronic inflammatory disease of the airways. In susceptible individuals, this inflammation gives rise to symptoms that are usually associated with widespread but variable airflow obstruction, which is reversible either spontaneously or with treatment and causes an increase in airway responsiveness to a variety of stimuli. So the other thing in this airway obstruction is that it is variable. That differentiates it from other conditions which lead to airway obstruction, which we can talk about in the differential diagnosis. I was just seeing your topic. I'm sorry, I just thought I am going to speak on the management of asthma, but there it is the approach to the asthma, and asthma is a huge topic. It's very difficult. I may not be touching all the aspects. You can ask me about we can interact and you can ask me questions and I can reply those. Now I'll be mainly dealing with, there are many types of asthma. You know about severe acute asthma is a life-threatening emergency, and then nocturnal asthma, exercise-induced asthma. I'm not talking about that, but the one which we come across daily for the management purpose is the chronic asthma, chronic persistent asthma. So chronic asthma is again, the definition will remain the same: inflammatory disorder of the airways. As a result of airway inflammation, the bronchi are hyperactive and narrow readily in response to a wide range of stimuli. The same definition. Whilst reversible initially, the inflammation may lead to irreversible airflow obstruction. So actually it is the pathogenesis of the asthma that if it is not intervened, if we don't give anti-inflammatory treatment, so ultimately what happens, the fibrosis starts to begin with in the peripheral airways, and the behavior of the disease from the reversibility changes to a persistent or irreversible airflow obstruction. Then the disease behaves like COPD. So that is how this has to be. At that stage, it becomes difficult to differentiate the disease from COPD. So naturally, concept should be clear. So this definition gives you the message that asthma has to be managed in a proper way. We'll be talking about that. Otherwise, the disease may become incurable. Now, the estimated total prevalence of asthma is around 7.2% of world population, and about 100 to 130 million individuals are affected with asthma. And it's more common in younger age, about 6% of the world's adults and 10% of children. So actually there's a lot of variation. You can see that prevalence of asthma is towards the increase worldwide, as shown in various recent studies that in Australia, children on asthma medication rose from 7% to 25% between 1982 to 1992. And you will be surprised that there is an international survey in which 56 countries were included, and Pakistan was also part of that. A questionnaire was put up to these children, and it was found about 8 to 9%, 8% or 9%. I was seeing the graph. The children in Pakistan were affected with asthma, whereas it was very high in UK, in Australia, and in New Zealand. There it is 38.5%. So you can well imagine. So it is towards increase, and male children are affected more, but sex ratio equalizes by the age of 30, and in urban population it's more common, and the reason may be the environmental pollution and overcrowding and others, fuel, exhaust, something. Now, my main because again on every aspect there can be 45 to 1 hour lecture which you talk about the pathogenesis of asthma and something like, just to give you the hint about that. So if you talk about asthma, so this is now that should be, although the physicians at times, but the mothers, the parents put a lot of restriction on the children that you will not take this thing, that thing, banana nahi khana, wheat nahi leni, doodh nahi pina, or a lot of things, khelna nahi hai, so otherwise you get asthma. So, but most of the time the asthma is because of airborne allergens. Airborne allergens, when they are inhaled, that is the antigens, they lead to the formation of the antibodies which are IgE. We all know that there are 5 types of antibodies, and IgE is found over there. Now here it is particular about that. When these IgE antibodies are formed, they attach themselves to the mast cells which lie in the surface epithelium of the airways. Now next time, on the next exposure to the same antigen, when that enters, someone inhales to that, so that antigen interacts with the antibody which has already attached to those mast cells. Now on the surface of the mast cells, because of the interaction of the antigen antibody, so there is a chemical reaction, a barhole is formed into the mast cells, and there is a release of the mediators. So that is the pathogenesis of that. And these are the histamine is released, bradykinin is released, and formally you have been reading that slow reacting substance of anaphylaxis. Now we know that that slow reacting substance of anaphylaxis, these are the leukotrienes and then interleukins. So there's a cascade of the reaction that leads to the inflammation in the airways, which affects the capillaries, vasculature, increasing their permeability, with the result that the cells come out of that, specifically the eosinophils, and the other cells, neutrophils, macrophages, and specifically under the influence of the leukotrienes, these eosinophils, they lead to this cytotoxic effects. So basic and cationic proteins and oxidants are released from these eosinophils. So they damage the cilia of the epithelium. Under the influence, direct effect of the leukotrienes, the secretions of the goblet cells, they are increased. There are more secretions, they become more viscid. And the smooth muscle, under the direct effect of these leukotrienes, that contracts. So, and there's more mucus production, there is more edema, there's more infiltration of the cells into the wall. All these things lead to the narrowing of the airways. So talking, most of the time we physicians say the bronchospasm. Bronchospasm is one element of the pathogenesis of airway obstruction. So there are other elements where there is edema of the mucous membrane, the goblet cells secrete more secretions, the mucus plugging, so that is there. So, and also the damage to the epithelium that's there. So this is how the narrowing occurs, and one gets an attack of that. Initially, this attack occurs after the exposure to these allergens within 15 to 20 minutes, and may subside on its own most of the time. And then there is a phase of 5 to 6 hours. After that, there is a delayed reaction which is persistent, and if the allergens are removed or you give some medication, only then you overcome the problem. Now coming back to the same slide, so if you see that how the leukotrienes are formed, so as I mentioned that the interaction of that and some membrane phospholipids, because of the under stimulus, they lead to the arachidonic acid release. And this arachidonic acid, that is two pathways. Cyclooxygenase pathway leads to thromboxane, that is the thrombosis. So actually this coagulability that increases, and for that you give to interact over here, you give dispirine, aspirin, NSAIDs, you give, they interact over here. And whereas on the other side, if you see that 5-lipoxygenase plus 5-lipoxygenase activating enzymes, so they lead to the production of leukotrienes. So these cistinal leukotrienes, so I have talked about that, how they produce the pathogenesis, the mechanism, they lead to the narrowing of the airways. Now the important thing is we'll be talking about amongst the triggers of asthma. So among the triggers of asthma, when we'll be talking about that, I feel appropriate so that your concept is clear over here. When we give aspirin or other NSAIDs, so what happens is they block this pathway in susceptible individuals. So when this pathway is blocked, so there is overproduction of this mechanism. so imbalance. So that leads to the further triggering of the asthmatic attack. So that is the mechanism for aspirin and NSAIDs, which trigger the asthmatic attacks in the susceptible individuals. So now that's important. I'm talking about not in everybody, only in susceptible who are genetically predisposed. So it is the genetic predisposition, it is the environmental factor, then it is the inflammatory process, antigen antibody, and then there are other triggers which come into the pathogenesis of asthma. Actually, it becomes at times so difficult that I remembered the saying of one of my senior colleagues, teacher. So it's just like the Chinese soup, which you take and you never know, so many things have been put into that and you go on taking that. Now the diagnosis for asthma. Now it's a classical history, episodic history. That is, in the attacks of breathlessness come in attacks, and in between the attacks the patient is symptom free. When there is a classical history, when there is a family history of similar episodes, when there is a history of allergy in the same individual or in the family of eczema and other hay fever is not here commonly seen, or allergic rhinitis is there. So there's a classical triad, as I mentioned, it's a syndrome. It's I'm sorry, probably sound is not coming. I'm trying to be as close to the mic as possible. Dur ho jaun? Is it okay? Now the thing should be clear that the symptom complex, as I mentioned earlier, there's cough, there is wheezing. That is, when we say wheezing, means audible bronchi. So the musical sounds which the patient will tell, and breathlessness. All the three components, when they are there, it's easy to diagnose, and the two of them may be there and only one of them may be there, and we'll be talking about that later. Specifically in children, the cough, the only cough presentation where you go on giving the antibiotics to a child and the child is not settling with that, you should think about that. That is asthma. This is called cough variant asthma. There may be no wheeze absolutely whatsoever. There may be no breathlessness, but only bouts of cough coming, maybe episodic, may not be, may have something like that. So the history is really very important, and then again it depends upon, because you know that in children we divide the asthma into two types: atopic or allergic asthma, which starts in childhood, and I have noted the whole history of that, what I've talked, and the other one, non-atopic, or atopic, early onset, non-atopic, late onset asthma. So late onset asthma usually start at the age of 35 or more than that. Usually these patients are aspirin intolerant, and again that contains a subgroup of exercise-induced asthma as well. And usually the history is not episodic. It's almost all the time persistent cough, and most of it is some sort of chronic persistent asthma. Then there are other type of asthma. If suddenly attacks comes, it is well controlled, but all of a sudden one gets severe attack and goes into acute exacerbation of that severe acute asthma, life-threatening. So that is labeled as brittle asthma. So some of the patients may experience asthma only during night, and then it is called nocturnal asthma. And nocturnal asthma has to be differentiated from paroxysmal nocturnal dyspnea of early left ventricular failure, from mitral stenosis, which may be silent. So that becomes the differential diagnosis for nocturnal asthma. And then exercise-induced asthma. And then there is exercises. Some people may only experience asthma during exercise, specifically in the children. And the term used for nocturnal asthma, for exercise-induced asthma, or for cough is factitious asthma at times. And that again, factitious asthma may again be variable, different ways. Factitious asthma, I'm sorry, not factitious asthma, there's a different name for that. But factitious asthma is specifically hysterical asthma, where there is closure of the glottis or of the larynx, quite often it's a female, and they also amongst the paramedics. So that is written in the books. So they close their glottis during inspiration or at expiration, and they're using a lot of that, and that's simulating asthma. And so the physical examination is, when we examine classically, there's no difficulty. The patient is dyspneic. So if you take the history, the patient will tell before the onset of the asthmatic attack there is tightness in the chest, and then patient starts hyperventilation, there is cough, there is a difficulty in breathing, which progressively increases, and in this way the patient, depending upon the severity of the disease, at times the attack may be too mild, at times moderate, and then we know the severe. So accordingly the patient uses the excessive muscles of the respiration, patient hyperventilates, there is hypoxia, and there is hypocarbia. If you go for ABGs, there is hypocarbia, and but if the carbon dioxide level in an asthmatic patient, if you go for ABGs, is normal or is increased, even a normal level of carbon dioxide is really tells you that it's a threatening, life-threatening asthma. So naturally now the patient, there's a respiratory failure. So, and when you examine that, the chest is more expanded, and percussion note is more resonant, and of course patient is using excessive muscles of respiration, all other signs of airway obstruction, that is the use of excessive muscles, recession of the intercostal spaces, recession of the supraclavicular fossa during inspiration, and tracheal tract, descent of the trachea more towards that. And in severest airway obstruction, there may be paradoxic movement of the costal margin, that is during inspiration it has to come out, and but instead of coming out during inspiration, it may be going in. So that is the paradoxic movement, and that tells us about the severest form of airway obstruction that may be seen in severe COPD or in severe acute attacks of asthma. So and on auscultation, the expiration is prolonged, and there are bronchi. Initially, in majority they are going to be expiratory, but as the disease progresses, they are also audible during inspiration as well. So I'm talking about chronic bronchial asthma or simple bronchial asthma, but the acute severe asthma is a different entity. It's more severe. Now the diagnosis and the management of asthma, I will have to talk about that together. Now the diagnosis is made on the basis of the history. Only difficulties come when I said that the patient, examine the patient, the history is there, nocturnal asthma, exercise-induced asthma, or the cough where there is no airway obstruction. So these are the 3 points where the physician is confused, or physician has to differentiate. So one has to go for lung function tests. The simplest way is the measurement. I'll be showing you the peak flow meter as well. I had brought, well, I had not brought that, I'm sorry, I forgot it, put it there, but I'll show you the diagram. So it's very simple, you might have seen, majority of you have seen that. So the thing is, the management of asthma, of course the diagnosis, the same tools are used. So there is a comment at this stage that treating asthma without measuring the airflow obstruction, that is the peak flow rate, is just like treating hypertension without measuring blood pressure. So it's very important to measure the airflow obstruction. It's a very simple instrument by which simply the patient has to blow into that after full inspiration, and you have to compare it with the chart. I'll be projecting that, and with that peak flow meter, peak flow rate, and there is diurnal variation. If there is more than 20%, so that diagnoses asthma. So the spirometry, FE1 FVC ratio, simply you don't need the full spirometry. If that is less than 65%, 70%, 75% of the predicted. So if that is simply, don't remember anything, if that is reduced, that tells airway obstruction. And then the reversibility test. And the reversibility test is you give 2 puffs of salbutamol to the patient, preferably through the spacer device. You measure peak flow rate, or you measure FE1, FVC in the beginning, and after giving that, you wait for 15 minutes. Although it becomes effective within 3 to 4 minutes after inhalation. So you measure it, and if there is change, if the peak flow rate has increased now, if FE1 FVC ratio has increased, so it means it is a reversible airway obstruction, and this is asthma. At times this reversibility may not be there, and then you give steroids 30 milligram daily for a fortnight, 14 to 15 days, and then you compare the spirometric reading in the beginning and at the end of the 15 days. If there is a change, so the reversible element is there, it is asthma. So the diagnosis should be clear, and measurement of allergic status to identify risk factors. Well, at times I'll be talking about that, whether the vaccination should be done or not. But you can go for allergic, for measurement of the allergic status to identify risk factors. So just the allergens are put on the flexor aspect of the forearm, and then they are picked by a stellate. And then the wheel flare reaction is observed. On the other side, a control is put in the same way to compare the two sides. And you can test a lot of antigens or allergens so that you know that. So to which things the individual is having allergy. But again, in the management, vaccination is not recommended. No, that's it is only, if you want to go for that, is for avoidance purpose. So that should be clear. Vaccination unanimously by British Thoracic Society, by Pakistan Society, even in USA or anywhere in the world, if you can go to internet, you can see any book, is not recommended routinely. Although in special circumstances, when everything is not working, it is refractory asthma as a last resort. And why it is not recommended in, I have not seen the recent edition of Davidson, but 4 or 5 years ago, in the beginning it was given the vaccination, immunotherapy, it is called immunotherapy, is effective only in 3% of the individuals. So in other words, there is 97% failure. So, well, I'm sorry, ये कलर कर सकते हैं आप इसको थोड़ा सा, ये slide local causes and then the generalized causes. So there is a long list. You can go and see the books and all that. So specifically in children, foreign body inhalation is really very important. Specifically the peanut inhalation. So foreign body inhalation and glottic dysfunction, as I mentioned there, factitious asthma, laryngeal carcinoma, tracheal carcinoma, bronchial carcinoma, they act as foreign body. So, and obstructive sleep apnea. I'll not go into detail. Then generalized causes, cardiac asthma. I have talked about paroxysmal nocturnal dyspnea, and similarly, you know that pulmonary edema that presents like cardiac. Specifically, important thing is if someone in the age of 50, in 50s or late 40s, presents with for the first time with the symptoms of asthma, the cardiac status must be checked up, because the people may get silent acute myocardial infarction. I had practically seen 4 or 5 cases while working in the Department of Medicine as well as in pulmonology, where the patient, one in Faisalabad while cycling developed breathlessness, was brought to the emergency, referred to the pulmonology department, and where we did is all the features of acute asthma. That was the cardiac asthma. The ECG clearly was very clear about acute MI. So silent infarction can occur in diabetics, in hypertensives, and in old age, and may present like asthmatic. So it's very important. So similarly is the COPD. So you have been taught about Dr. Solut took the lecture on COPD. So you know that. So that comes in the differential diagnosis very much on that, and specifically the subset of the individuals who are smokers as well. So asthmatic bronchitis and asthmatic patients who smoke ultimately may develop COPD as well. So it becomes difficult at times when they present. And then bronchiectasis, quite often there is this asthmatic symptoms in the cystic fibrosis is the other one, which is really very important in children where they wheeze all the time and there are symptoms of all that and recurrent infections. And obstructive obliterans bronchiolitis is another condition which mimics. There are a lot of other conditions. I'm not talking about this long list. 12, 13 conditions where the differential diagnosis for the retrosternal goiter is one of the differential diagnoses for asthma. And this when tracheostomy, post-tracheostomy stenosis of the trachea, so that may be confused with asthma. And asthma triggers. Now allergens, so you can remember it like English vowels, A, E, I, O, U. So A stands for allergens, we talked about that, air pollution, aspirin, intolerance, and E for emotional stress. So even you may come across the people who may tell you that when they laugh loudly, the laughter that brings attacks of cough, they can't laugh loudly. So that is, they are practically asthmatics. And extreme happiness, extreme sourness may trigger asthma. So you can well imagine where you stand, where are the allergens. So it has got a lot of underlying mechanisms. Similarly, we have talked about exercise and extremes of cold and heat. Both in winter and in very hot temperature, the asthmatics, they get attacks of asthma. Infections, specifically upper respiratory tract infections, viral, so they trigger asthmatics in both groups, early onset and late onset. And occupational factors, some of the occupations which lead to the asthma, like byssinosis, although that is grouped as a separate entity. So, and there may be others unidentified. So viral infections, influenza, parainfluenza, adenoviruses and others, respiratory syncytial virus, allergens such as domestic dust mites, this is really very important, very, very important. And animals with fur, that is cats, it's really very important. Even these dogs which are kept at home, cockroaches are very important factor which lead to asthmatic attacks, pollens and molds. Tobacco smoke, both active and passive smoking, air pollution, exercise, strong emotional expression, and chemical irritants, they all lead to the asthmatic attacks. Now, what are the goals of long-term management? We have to achieve and maintain the control of symptoms, prevent asthmatic episodes or attacks, maintain pulmonary function as close to the normal levels as possible, maintain normal activity levels including exercise, avoid adverse effects from asthma medications, prevent development of irreversible airflow limitation as I mentioned early in the definition of. So that has to be prevented, and prevent asthma mortality. So these are the goals of long-term management of asthma, and there will be repetition in the in 2-3 slides. So minimally, ideally there should be no chronic symptoms, and minimal or infrequent exacerbation should be there. There should be no emergency visits, that is the ideal control of asthma. Minimal, ideally no need for as needed use of beta-2 agonists, no limitation on activities including exercise, peak expiratory flow, circadian variation of less than 20%, near normal peak expiratory flow, and minimal or no adverse effects from the medicines. Now asthma is underdiagnosed. So it's really very important. I have talked about that, about the cough variant asthma, exercise-induced asthma, and nocturnal asthma. So the asthma has to be diagnosed to abolish symptoms, to restore normal at best possible long-term airway function, to reduce the risk of severe attacks, to enable normal growth to occur in children, to minimize absence from school or work. All aims to be achieved without inappropriate restriction on lifestyle. मेरा ख्याल है मैं ज़रा जल्दी कर लूँ, मुझे लगता है कि आप लोग थक गए हैं. That's I'm judging. And now I'll not go in detail. Now, in difficult situations, is it asthma, recurrent episodes of wheezing, troublesome cough at night, cough or wheeze after exercise, cough, wheeze or chest tightness after exposure to airborne allergens or pollutants, colds which go to the chest or take more than 10 days to clear. So if these things are there, you should think about it's quite often it's going to be asthma. Now this is really very important. So when the children are affected or some individual is affected, you all know. मरीज पूछता है जी मेरे बच्चे का क्या बनेगा, कब तक दवाइयाँ लेनी है, मैंने कब तक दवाइयाँ लेनी हैं. और इनहेलर के बारे में बहुत सारी क्वेरीज होती हैं. मैं इनहेलर नहीं लेना चाहता, सोसाइटी में बुरा समझा जाता है, ठीक है, इसकी मुझे आदत पड़ जाएगी. तो ये बहुत सारे सवाल आते हैं. तो इसमें पेशेंट की एजुकेशन जो है वो ज़रूरी है. उनको ये बताना है अवॉइडेंस ऑफ आइडेंटिफाइड काजेज वेयर पॉसिबल. क्या खाना है क्या नहीं खाना मुझे नहीं पता, आप क्या कहते हैं, ऑल ऑफ यू आर प्रैक्टिसिंग. तो एज ए चेस्ट फिजिशियन वी डोंट रिकमेंड एनी इनहिबिशन. किसी किस्म की पाबंदी, खाने पर पाबंदी नहीं लगानी बच्चे की. बच्चे पर पाबंदी लगाएंगे तो ग्रो कैसे वो करेगा, ठीक है. तो मैं उन्हें छोटा सा कह देता हूँ, सीज़न का जो है वो इश्तहार आपने सुना होगा, मैं खाऊंगा नहीं तो बड़ा कैसे होऊंगा. तो वो आप मतलब मैं ये सिंपल मैं कहता हूँ कि आप नो रिस्ट्रिक्शंस, ठीक है, खाऊंगा नहीं तो बड़ा कैसे होऊंगा. और पेशेंट को फिर बताना पड़ता है इफ़ द एस्थमा इज़ नॉट कंट्रोल्ड. आपने देखा होगा पिजन चेस्ट. So growth retardation is there and pigeon chest is there, so they all has to be avoided. So and if you can explain to the parents that these things can be avoided, your child will grow to the normal height and will be successful in every field of life. So they do agree for the inhalation therapy. Now, use of the lowest effective dose of convenient medication, minimizing short and long-term side effects. To educate the parents, patients and family regarding nature of the disease and its treatment, to enable them to understand the management skills, to encourage expression of their fears and concerns about disease and its treatment, and to discuss their expectation of condition and its management. All patients and parents require both verbal and written advice. मैंने अपनी लिख कर रखी हुई है, वो हर पेशेंट को थमा देता हूँ. And that is total information about asthma. No slogan. It's a brief summary of that. This partnership should ensure the patient and family to form realistic expectation, and this is the expectation. They should be made clear that cure or spontaneous permission of chronic asthma in adults is unlikely, and therefore treatment and supervision are likely to be required for a prolonged period. तो मैं अपने पेशेंट को ये कहता हूँ कि दमादम के साथ ही जाना है. अब सोसाइटी को पता है कि हाइपरटेंशन डायबिटीज़ का सोसाइटी को काफ़ी पता चल गया, तो उनको बताता हूँ कि जिस तरह हाइपरटेंशन का ट्रीटमेंट आपने सारी ज़िंदगी करना है, अगर आप नहीं करेंगे तो फालज हो जाएगा, दिल का दौरा पड़ जाएगा, अंधापन हो जाएगा, गुर्दे फेल हो जाएंगे. शुगर का करना है, उसकी कॉम्प्लिकेशन. इसी तरह आपने दमे का इलाज करना है. अगर नहीं करेंगे तो नताइज मुख्तलिफ होंगे, लेकिन एक बात है कि दमे का प्रोफाइल हाइपरटेंशन और डायबिटीज़ से बेहतर है, ठीक है. एक और एजुकेशन में हमने पेशेंट को जो बात बतानी है वो ये है, एज फॉर डायबिटिक पेशेंट्स वी टेल देम, वी गिव देम अ प्लान फॉर देयर ओन सेल्फ मैनेजमेंट, so they can modulate their day-to-day requirement of the insulin or their oral hypoglycemic agents. If they take less, they decrease the dose. If they take more, they can just increase their units. Similarly, that the patient should be informed about when they can start the steroids on their own. So that's really very important. So avoidance. So the avoidance is really very important. So allergens, house dust mites, domestic pets, pollen. So pets should be removed from the house. And there should be simply removing extra furniture from the patient's room. The carpets should not be there ideally, and if they are there, then there should be no dry dusting, there should be vacuum cleaning. The pillow covers, the bed sheets, these are ordinary things, but they should be changed weekly because they are full of dust mites. The cockroaches should be controlled. And can you ask someone to change the occupation? Very difficult. Once I asked one of my patients to change the occupation, he said, Doctor, well, if someone asks you to change your profession, how you will behave? So it's really very difficult situation. So you have to tackle it. So you have to avoid these drugs, beta blockers specifically. A common thing presenting with severe cough nowadays is the ACE inhibitors. Anybody who comes to you in your private practice who is coughing, always look into that, whether someone is taking ACE inhibitors. So you stop that, the cough goes away, and you can change to calcium channel blocker. It's very simply. And the smoking should not be there. So this is important. Inhaled beta-2 agonist, reliever therapy and preventive therapy. Inhaled beta-2 agonist, oral injectable beta-2 agonist, oral injectable methylxanthines, and preventive therapy, that is the inhaled steroids, inhaled compounds, oral steroids, oral methylxanthines, oral leukotriene antagonists, and oral steroid sparing agents. Inhaled beta-2 agonists and anti-inflammatory agents are the mainstay of asthma management, so that's really very important. Now the severity of the asthma should be assessed. So it is divided into 4 steps: step 1, step 2, step 3, step 4. So if the patient gets occasionally attacks, the patient does not need any controller or preventive medicine. What needs is SOS bronchodilator, and that also in the inhaled form. Step 2 is if the symptoms are more, but now although it's this very decision that the symptoms are more than 1 time a week, but less than 1 time a day, or more than 2 times a month at night, nighttime symptoms. These are nighttime symptoms. So, and then if it further worsens, so you can simply remember, you give, we'll be talking about that, you give inhalers to these patient, you give leukotrienes and all that, but the symptoms are not controlled, so the patient enters into severe persistent form, where you will have to give almost everything to the patient. So that's really very important. When the patient needs all the time some medication in the form of maybe oral form tablets or inhalers, cannot do without that, cannot sleep at night. The symptoms are frequent at night, so that is the step 4, that is the severity. So we have talked about 4 steps of asthma, and in step 3, what is desirable? We should try to control asthma. The outcome should be asthma control. And at step 4, the outcome desirable is best possible results, that we should be able to control the symptoms. And if we succeed in that, when asthma is controlled for more than 3 months, for 3 months or more, then we should try to reduce the drugs. Now this has been simplified. Step 1, you don't need any controller medication, only intermittent bronchodilation, salbutamol, something like that. Step 2, the mainstay is inhaled corticosteroids. Actually, this is the step where if your patient is reluctant to take this, there is a lot of influx of montelukast in the market. And probably I strongly feel that is misused. But these are the individuals who can be controlled alone on the leukotriene modifiers. That's montelukast and zefalukast. I don't think, how many of you know zefalukast? Very few. Accolate. So Accolate and Singulair, the master drugs, they are equally good. You can select any one of them or me too according to the need. Step 3. Now here, inhaled glucocorticosteroids, this is the daily control medication, plus long-acting inhaled beta-2 agonist, that is LABA, that is solmetrol, formoterol. And if you fail to control that, so then you can add up some nicotine modifier or some theophylline to the same regimen. But the ideal control would be, if the beta-2 agonist is not required more than 3 to 4 times a day, and once control is achieved and maintained for at least 3 months, gradual reduction therapy should be done. ये तो 5 मिनट में हो जाएगा, 10 मिनट्स तो आपने ज़्यादा बता दिए मुझे यार. Now step 4. I'm going to finish it within 5 minutes. मुझे बताया इन्होंने 10 मिनट्स का है. Don't worry. So daily control medication, inhaled glucocorticoids more than 1000 microgram budesonide, propionate or beclomethasone, plus long-acting inhaled beta-2 agonist, plus 1 or more of the following if needed. So here these are the individual where you would like to give even the oral medication like bronchodilators, like salbutamol, like Meprin, like Bremax, the others, and these are the individuals where you would like to give them, and you can give the nicotine. You give everything to these individuals to control. Even the oral steroids may be needed at times. Now in children, it's the similar way to control asthma. So step 1 is intermittent therapy like way. Step 2 is similar, but in children the maximum allowance for inhaled corticosteroid is 400 microgram. And specifically you should be clear about that. It's the budesonide which does not lead to the growth retardation. So we have in the market budesonide, that is Pulmicort, and beclomethasone, that is Clenil. And but even the beclomethasone, the growth is ultimately attained to a normal level. It's similar, the allowance is less than, its maximum is 800 microgram of the budesonide, but the other things are similar to the adult asthma control. And again it's similar. Now the management, it's a management, so it's the query about the ketotifen, the role of ketotifen. वैसे तो आप सब गप्पी लगा रहे हैं, मेरा ख्याल है बंद ही कर दें फिर. ज़रा लाइट ऑन करें यार. ये मुझे बताएं कि कीटोटिफन कितने लोग इस्तेमाल करते हैं. कोई हर्ज नहीं है इसमें. तो मेरे आज के लेक्चर का मकसद यही था कि अगर मैं आपकी 2 चीज़ें ठीक कराने में कामयाब हो जाऊं. मैंने रखी भी थी अपने साथ ब्रिटिश, किसी को चाहिए तो मेरे पास काफ़ी पड़ी हुई है कापियाँ, ब्रिटिश थोरेसिक सोसाइटी की एस्मा गाइडलाइंस. हमारी इसमें भी आपको दिया है, कंसेंसस में बड़ा क्लियरली लिखना है. कीटोटिफेन इज़ एन एंटीहिस्टामिन, नॉट मोर देन दैट, and is not recommended for asthma controller medication anywhere in the world. जी सर, that is recommended. But now it is less used. But there's no controversy about that. But the market's not there. And similar, गायब हो गया. So Islamabad business probably may be recommended to few of the individuals. I don't say don't recommend it. You can recommend, but not to everybody. But not that way. आप बिलीव करें 10 साल पहले मुझे ठीक है वो पेशेंट ने तभी मेरे पास आना था, मेरे पास तो रेफर केस आना होता है. मियाँ चन्नू से एक खातून को वहाँ नेचुरली मैं समझता हूँ कोई ऐसी बात नहीं है, एस्मा कंट्रोल नहीं हो रहा है, वहाँ भेज दिया उसको इस्लामाबाद के आप वैक्सीनेशन करवाएं, लेकिन वहाँ था क्या, इट वाज कार्डियक फेलर, कार्डियक एस्मा. देयर शी हैज़ टू गो इनटू इमरजेंसी. मैंने मिला नहीं कभी, डॉक्टर उमर हैं, मुझे पता है प्रोफेसर मेडिसिन है, उनके अंडर ट्रीटमेंट रही, एंड देन शी शिफ्टेड टू लाहौर. तो मेरे जाने वाला था मेरे पास. सो एक्चुअली इफ द पेशेंट इज़ नॉट सेटलिंग, लुक इनटू दैट, देयर मे बी सम डिफरेंट डायग्नोसिस. सो इट्स now if your patient is not improving upon that, so what can be the possibilities? Difficulties associated medication uses with inhalers, complicated regimens, fears about are actual side effects, and the cost the patient not purchasing the inhalers and other things. So patient-physician misunderstanding, lack of information, underestimation of the severity, attitudes towards ill health, cultural factors, and poor communication. Review treatment every 3 to 6 months. By monitoring symptoms, peak expiratory flow, number of attacks, severity of attacks, and frequency of use of reliever medication, step down. If control sustained for at least 3 months, gradual stepwise reduction 25 to 50% in treatment is possible. Step up. If control is not achieved, consider step up. But first review patient medication technique, compliance, and environment control. Avoidance of allergens or other trigger factors. This is the peak flow meter, and this is the chart where you can compare. This normal chart. This is for European Union, but somehow you can apply it to that as well. This is for women. It's similar, and it can be peak expiratory flow liters per minute, and then this is the age per year. So this is you can compare patients with these. And again, this is for men, and these are separate different devices. So one thing should be clear, that when you use the spacer device for administering inhaler, the dose is doubled. The side effects are minimized. The patient don't have to learn the technique of taking inhaler. And specifically for children, I learned it from one of my patients, of a child's mother who was too wise. And simply she asked, just suck it like you are taking juice. So she pushed the inhaler into that. So you can always tell that just suck it like a juice. So and a lot of children can take the juice. So the similar normally 4 or 5 inhalations so can be taken. So these are all inhalers. Some are actuated. Some are. This is a dry powder inhaler now available in Pakistan. So, and clanopulvinal, only one preparation available in Pakistan. So this is the discus. Dry powder inhalers, and so there are breath actuated inhalers as well. When shake it, put it in your mouth, start inhalation, it will fire on its own, and the patient continues to inhale. You don't have to push that. That is a breath actuated inhaler. So that tells us that if I go for a technique, if you would like for anyway, I had brought certain devices. If you want, I can demonstrate. And your idea should be clear about that. About the inhaler, preferable would be that the inhaler should be taken with a device. The controller medicine, that the steroid inhaler should be in the bedroom at the bedside, and patient can use it through the spacer device in the morning and at the evening. And this salbutamol, maybe any company, it's a different somehow, so it should be kept in the pocket, and whenever someone feels difficulty in breathing, that should be used. But the technique has to be correct. So it, first of all, you shake it well, put it in your mouth, close the lips. Now important thing is start inhalation first. Some people will tell, ये दो बातें हैं आपके लिए. ये मैंने अभी breath actuated inhaler की बात की है. You start inhalation, it fires. Companies ने, I'm definite, they do try to penetrate with all of you. कुछ अर्सा पहले तक वो कुछ whistles देते थे. They will say, shake it, put the whistle over there, put it in your mouth, start inhalation. When the whistle blows, then press it. So what does that tell? That tells that first you have to start the breath inspiration, and only then you press it. And initially one should try in front of the mirror. And if the aerosol comes from the mouth, from the sides, or from the top of that, so the technique is wrong. So one has to take in a normal way. Now there is a concept that the other concept came that it should be kept about 3-4 inches away from the mouth. But to me it becomes very difficult to take that way. Occasionally, the last few days ago, I took it for 2-3 days after 5-6 years. So I'm potentially asthmatic. So it's very easy to take it. I can take it I think most of you, if you like, I can show it. I'll take only 1 dose of Ventolin. It's my own inhaler. So I'll use it. Just putting it over there. You have to hold it till you can 10 seconds. And I'm sure you didn't see any sort of aerosol from the side or from above. So first you start inhalation. The other way is that you use the spacer device. Inhaler is the most, I think, most easily taken. You can take it. This I call it feminine. This valve. This is one-way valve. And I had come across, even after explanation, the people have even the man who is working at the medical store advised to remove it. At least 4 or 5 cases I have seen where they removed it. So it has not. It has not to be removed. The inner surface has not to be wiped. It has to be kept clean, crystal clear, and always use a detergent soap. Put it over there. Now disassemble it, put it into that, keep it there for 15 minutes. That is the recommendation. And then open up the tap, rinse it over there. Do not wipe the inner surface. And the reason is quite obvious, although you don't get the detail of that. There are electromagnetic forces on the inner surface of these spacer devices which